Hi, this is Elliot Fishman, and welcome to part 2 of evaluation of challenging adrenal masses. We left off last time with a statement talking about how a 4 centimeter lesion, water density, which means under 10 Hounsfield units, you can consider that to be an adenoma. However, if it's over 10 Hounsfield units, then you have to look at washout value with the absolute washout of 60% and a relative washout of greater 40%, making it an adenoma. So let's look at some examples. Here's a very simple case. Incidental lesion, very well defined. This is water density. This is an adenoma. Again, you can see I drew a circle that's about 1 centimeter in size, placed it in the middle. You can see there's a standard deviation, there's a min, there's a max. We don't look at that. We look at the mean. The mean is 0. Next case, adenoma. Another example, left adrenal gland. Well-defined, 2.5 centimeters, non-contrast 6 Hounsfield units. That's going to be an adenoma. Nothing else needs to be done. But what about that same patient? If they would have had contrast, the adrenal is 67 Hounsfield units on arterial phase. This was part of a kidney study. So you could see that benign adenomas that would measure 6 on non-contrast will enhance. And that's really the point. When we have non-contrast scans alone, it's easy to make a diagnosis of adenoma, no adenoma. Once you give contrast, it's hard. So either you need to look at the washout value, the relative washout value, or you need to bring the patient back for a non-contrast scan. You can see in this case that same adrenal was 56 on venous, and the late scan was 18, so washed out significantly, so you're comfortable this is an adenoma. But if you only have a single phase, be it arterial or venous, you can look at the lesion and say it looks benign, there's no clinical history, but there's no way you can call it an adenoma without making mistakes in a significant portion of cases. So again, look at those numbers. It's important to realize how quickly adenomas wash out, but also remember that PHIOs wash out quickly, METs can wash out quickly. Of course, with PHIO, the typical attenuation on arterial or venous is going to be above 120 Hounsfield units. With the very vascular METs like renal cell, the same thing will hold true. Those are the washout values. The absolute is what we like best, but if you don't have non-contrast, you can use the relative washout. Remember, the absolute washout, 60%, relative 40%. Now, we mentioned that when we do delayed scans, typically when we look at an adrenal workup, you do a non-contrast, you inject 100 cc's of contrast, you scan at 1 minute, which is basically venous phase, and then you come back at 15 minutes. Now, 15 minutes is a long wait. People have tried doing a 10-minute wait, but you can see test accuracy was much lower. So, yes, sometimes things can wash out at 10 minutes. Most of the time, it's going to take you 15 minutes, so just get over it. Wait the 15 minutes. Now, we mentioned the part about adenomas not always being under 10 Hounsfield units and why the adrenal protocol works so nicely. Here's an incidental left adrenal lesion, 24 Hounsfield units. It could be an adenoma, but we can't prove it unless we give contrast. We give contrast, it goes to 56, and then at 15 minutes it washes out to 28. That's an adenoma, greater than a 60% washout value. Very, very easy to make the call. Now, facts to remember. Now, one of the things when you start looking back at the literature and people talk about that 60% rule, they always talk about that as all cases because they always seem to forget about pheochromocytomas. And in the original articles, they always assumed that people could diagnose PHIOs and it would never be confusion. These days, of course, we know that more than half the PHIOs are actually incidental findings. It's not like anyone is suspicious for PHIO. So again, you have to be very, very careful. And when I speak about PHIOs a little bit later in this talk, you'll see some examples of what I'm thinking about. Here was an article by Norcott we wrote a number of years ago talking about arterial phase enhancement above 110 should make one consider the possibility of PHIO. Some people say 120, but I say 110 works well. I don't really see many adenomas at 110. Occasionally I will see that, but it's always good, it's maybe not bad to get a metanephrine level just to be certain you're making the right diagnosis. And here's just a simple example. If you look at this case, the right adrenal gland, there's an adenoma present, possibly 39 Hounsfield units, but it's indeterminate. But when you give IV contrast, you can see how that enhances to 120. That was a pheo. Or this patient with back pain, what about this right adrenal lesion? There's some rim enhancement. You go to the venous phase, look at all of that vascularity. I would admit it's a funny appearance. Most pheos are homogeneously or diffusely enhancing, though we do know that pheos can be cystic, but this is kind of looking almost like a hemangioma of the liver. You have a lot of peripheral enhancement, and the lesion is fairly homogeneous in terms of enhancement otherwise. Well, believe it or not, that was an adenoma. So there is a challenge. Things are never that simple. Pheos can simulate adenomas, and they can be overlap, and adenomas may not look like adenomas. We've had a number of large adenomas that have been resected because they look like solid masses. So just to make the point, adenomas can be large. Remember, they were 1/3 of the lesions above 4 cm in that Mayo series, so things are never as simple. Now, in this article by Corwin, talking about management of incidental adrenal nodules, the ACR guidelines were done till 2017, yet the management of indeterminate adrenal incidentalomas was highly variable with no single management option reaching majority. Hormonal evaluation and endocrine consultation were most often rarely or never recommended. The results of the survey indicate wide variability in the interpretation of imaging findings, and management recommendations for incidental adrenal nodules among surveyed radiologists. Further standardization is necessary. And that's the reason, in great part, we're giving this talk, because adrenal lesions are one of the classic things we do in CT, and it's amazing how there is such discrepancy. And look at this. This is from abdominal imaging from his article. What would you recommend for this incidental 1.7 right adrenal nodule over 10 Hounsfield units on contrast CT in a patient with no history of cancer? And you could see adrenal protocol now in 6 months, immediately, don't bother. You know, a lot of variability. One thing we should be careful about in radiology is that we reach criteria that are the best to our knowledge, and then we follow them. You need to have specific criteria if you want to really manage patients well and not create confusion within your group or within radiology in general. So again, Corwin made the comment, the majority of respondents either rarely or never recommend hormonal evaluation. That becomes very important because the American Association of Clinical Endocrinologists and the European Society of Endocrinology both recommend hormonal evaluation to determine the functional activity in all patients with adrenal incidentalomas. Now that's expensive, right? Every incidental lesion, you got to send the patient back for lab tests. Who's going to order them? Who's going to monitor them? There aren't that many endocrinologists around, so it's something that sounds really good, but typically is not happening in practice. In this article by Chung, again, it may be impossible to distinguish a large atypical adenoma from an ACC if there are no benign diagnostic features. Again, looking at the entire picture, including hormonal assessment, is essential. But I will tell you, as mentioned, even in multidisciplinary conference, we can't always conclude that what is the right way of managing the patient or specifically what the lesion is, which is why you've seen us and you've seen everybody operate on greater than 4 cm adrenal adenomas, on old hematomas, on other benign lesions that simulate malignancies. So let's look at some lesions very specifically. Adrenal cysts. Typically it's easy. Water density, thin wall may be seen but does not enhance and occasionally can calcify. In this article, in press, most patients with adrenal cysts are asymptomatic. However, 10% present with symptoms of mass effect, such as abdominal pain and discomfort. So it's very important to recognize that you can have symptoms even from benign lesions, and we know that. The same thing is true with myelolipomas. There you can get pain. The concern more is of bleeding, and so a myelolipoma of the adrenal over 5 cm will typically be operated on. In this article, the prevalence of symptoms of mass effect in patients with cysts over 5 cm was 20%, which is tenfold higher than in cysts under 5%. Okay, so I think the point is that sometimes you will have to operate even though you know it's a benign lesion just because the patient is symptomatic. We know the same thing is true in splenic lesions. We know the same thing is true in liver lesions, and occasionally is true also in renal lesions. Here's a nice example of an adrenal cyst, water density, well defined. Coronal views are especially helpful to me. Sometimes you can't tell adrenal from renal. It makes it very easy on the coronals, also gives you a better feel of margins and interface. And coronals as well as 3D imaging can be very valuable to the surgeon when they're planning laparoscopic surgery. In that same article by Kalissendorf, in the absence of symptoms or functionality, the best management for adrenal cysts is not clear. When a cyst is accidentally discovered without clear-cut benign imaging characteristics, whether the patient should undergo follow-up imaging for detection of growth is also not clear. In addition, the ideal frequency and length of follow-up is unknown. Most benign adrenal cysts are asymptomatic, but they may grow and give rise to symptoms of mass effect. The predictors of growth or potential hemorrhage are unclear, and thus monitoring should be individualized. The pathologic drivers behind the development of adrenal cysts and growth are also incompletely understood. That article is Impress 2023. You asked me 15 years ago, an adrenal cyst is an adrenal cyst, let's not worry about it. Now you can see people are rethinking many of the things. Here was a patient with some pain and a cystic lesion of the adrenal with rim calcification. Now, I usually say, in fact I always say, if you see an adrenal lesion with dense rim calcification, it means it's old hemorrhage. This was resected because the patient had pain. There was no concern for malignancy despite its size. This ended up being an endothelial cyst with wall calcification. There was no hemorrhage present. So again, cysts can calcify. You can see how dense the calcification was in the rim. Very important. In that same article by Chung, because the attenuation of simple fluid is less than or equal to 10 Hounsfield units, a homogeneous unilocular cystic adrenal lesion can mimic adenoma. Again, as I mentioned, mimicking adenoma is not a problem. They're both benign lesions. They talk about how cystic lesions can simulate cystic Mets or pheochromocytoma. I don't think that's the problem because with adrenal cysts, you're not going to have the thickened rim. When I show you examples of Mets or pheos that are cystic, they're irregular, there's thick walls. So in theory, there can be overlap. To me, in practice, there isn't any. Let's look at one more tumor, myelolipomas. They're benign always. They're non-functioning. Usually it's an older patient composed of mature fat cells and hemopoietic tissue. Calcifications are not uncommon, and at times, particularly those cases with minimal fat, punctate calcifications makes me very comfortable that I'm dealing with a myelolipoma. Size can be from a couple centimeters to really 17 centimeters or greater. They contain macroscopic fat, which is usually an attenuation of under 20 Hounsfield units on CT, and signal dropout on fat-suppressed MRI sequences. In theory, you could see macroscopic fat in adenomas, in ACCs, and pheos, but it's really not going to be a problem. That's so rare. When you see fat in a myelolipoma, you can tell what you're dealing with. In an ACC, when you see fat, you also see significant vascularity. It's just one component of a very aggressive mass. In theory, occasionally very large myelolipomas can be difficult to distinguish from liposarcomas. Myelolipomas can grow over time. They can get smaller or they can stay the same. The biggest complication is going to be due to hemorrhage. These days, usually above 5 centimeters, you will get elective surgery. If patients are symptomatic and the lesions are smaller, they'll get elective surgery. Again, it's not because of concern for these lesions becoming malignant. It's just concern for the patient spontaneously bleeding. myelolipomas have no pre-malignant potential. So some examples: a small 2-centimeter myelolipoma, right adrenal gland, 100% fat, no difficulty making the diagnosis. A 5-centimeter one. In this case, you see a little bit of swirling. Whenever you see swirling in a patient with a myelolipoma, it usually means it bled at some point. So a case like this, it's in the 5 cm range, it bled previously, this patient is likely going to get surgery if they have any symptoms at all. Even if they had no symptoms, it would be considered as well. Here's another example of increased density within a left adrenal myelolipoma, very nicely shown again on the coronal view. Here's one, left adrenal, punctate calcifications, punctate areas of fat. Yes, not all the lesion is fat, like the last cases I showed you, but this is classic 100% myelolipoma. I would not give a differential diagnosis. And again, punctate calcifications, even with very minimal fat, make me always make the call of a myelolipoma. You can see the fat right there and the calcifications right there. Another example, even a larger lesion, multiple calcifications, fat. Again, you want to be careful. You don't want to call this a metastatic disease. It's picked up in older patients. Older patients have malignancies. You don't want to be doing a major workup for nothing. Occasionally, myelolipomas can be positive on PET because they have brown fat. So CT can be very helpful because if you only looked at the PET, you would say metastatic disease, while really it's a myelolipoma. Again, here it is very nicely on the coronal views. Here's one, larger one with higher density. That means this lesion previously bled. The patient was presenting with acute pain, and this patient will get a right adrenalectomy electively. Here's another one, a lot of fat present. You can see in this case, this is the one you look at and you say, could this be a liposarcoma? Liposarcomas are the #1 retroperitoneal mass. They have a variability in terms of fat, but this could be a liposarcoma. I have to admit that indeed is a possibility. Now, I mentioned hemorrhage as the reason for operating in myelolipomas. Hemorrhage can be due to many, many different causes. Typically, high CT attenuation in non-contrast studies can be unilateral or bilateral, and in time, hemorrhage will calcify. It's more common in females. One of the interesting things about hemorrhage, it can present as adrenal insufficiency, meaning the patient is Addisonian, and CT is the way to make the diagnosis. Clinically, the patients can present with acute abdomen, myocardial infarction, or sepsis, so it can be very confusing. Causes of adrenal hemorrhage: coumadin, underlying tumors, trauma, infection, hypercoagulability, or stress. Adrenal masses that more commonly bleed: PHEOs, #1 on the list, METs, ACC, myelolipoma, and adenoma. When you look at the trauma, that's really where things were classically described: an oval lesion, high density, stranding around the gland, most common in the right adrenal gland, and commonly associated with renal or liver injuries at the same time. In trauma, usually it's going to be unilateral. Here's a very nice example of hemorrhage. The adrenal is large, it's high density, lots of stranding around the adrenal and around the kidney, and this was due to coumadin. Here's another example with bilateral hemorrhage due to coumadin. Anticoagulant therapy is one of the causes of bilateral adrenal hemorrhage. Again, very nicely seen, oval, like the description for trauma, and then swirling all around the adrenal lesions. Here's another example. This was a patient who was an ICU patient, had a benign meningioma resected, was doing poorly. They thought maybe the patient had an abscess, something going on. They couldn't figure out why. Well, bilateral dense adrenals, bilateral hemorrhage. We called up immediately. We said the patient is probably Addisonian. That was the case. We saved the patient's life. It's rare for us to ever get recs that say rule out Addisonian crisis and adrenal hemorrhage, except for the 2 weeks that follow when you make a diagnosis like this. Now, in terms of metastasis or primary tumors, Mets can bleed, and sometimes it's the presentation. This patient presented with right upper quadrant pain. The thought was kidney or gallbladder. Well, there's a large bleed. When you have a large bleed, you may obscure the mass present. This was eventually diagnosed as a lung cancer metastatic to the adrenal. Look at this example. Now, this was a patient with an incidental finding of this large right adrenal lesion. And this is the point I made before. We've seen atypical adenomas. I showed you that. This was resected because we couldn't figure out what it was. It wasn't aggressive. It wasn't enhancing, but it was a large mass. The patient had at best minimal to no symptoms, but no one felt comfortable leaving this alone. You wouldn't want to biopsy it because it could be an ACC. At path, this was a large hematoma. It was not recent bleeding, it was older blood, but hematomas can present as large adrenal masses and can be a really difficult diagnosis. Again, you could think about all the possibilities. This patient was very lucky. It was a benign lesion. So again, very, very important to think about. Again, in this recent article by Chung, there are no established guidelines for follow-up to assess for an underlying mass after resolution for hemorrhage. However, follow-up is warranted and 6 to 12 weeks is reasonable. The reason you want to follow patients, of course, is you want to make sure there's no underlying tumor present. As I mentioned, sometimes tumors can rupture. You may not see them. A couple cases I've seen, we've done the entire chest and abdomen. We picked up lung cancer. You can have FEOs that bleed, so perhaps early on they will routinely get lab values. So if this was a FEO, you'd be able to make the diagnosis. But again, there are no specific guidelines. You need to follow the patient. That's the number one guideline. And usually 6 to 8 weeks is what we typically will do. Now, hemorrhage is a rare complication. As we mentioned, FEO is the most common primary tumor to bleed. It's one of the interesting things about pheochromocytoma. It's really unknown why they bleed. Some theories suggest increased intracapsular pressure from trauma, a rapidly enlarging tumor that outgrows its blood supply, and many other possibilities. But again, when you see spontaneous bleed in adrenal lesion, think about pheochromocytoma. Now, what if you have prior hemorrhage? Here's a good example. Calcification is one of the things we mentioned about prior hemorrhage. It can be a circular lesion with rim calcification. It could be atrophic looking glands with dense calcification looking very much like TB or histoplasmosis, for example, really dense calcifications. Or here's an old adrenal hematoma with rim-like calcifications. Again, as I mentioned to you, if I see rim-like calcification very thick, to me it's old hemorrhage. I won't always be right. I showed you the benign cyst before, but it's going to end up being a benign lesion. Okay, what about malignant tumors? Let's talk about them, but before we do, let's take a break and come back. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.